Welcome to the Australian Dental Council Explainer podcast. This episode analyzes Case 2 from Odell's Clinical Problem Solving in Dentistry for educational purposes. When presented with a soap bubble jaw lesion during an OSCE, the immediate instinct is to offer a diagnosis based on visual pattern recognition. However, in a professional examination, and certainly in clinical practice, success depends on a systematic assessment of the evidence before reaching a conclusion. Our case involves a 45-year-old African male presenting to the Accident and Emergency Department. His medical history indicates he is fit and healthy, with no pre-existing conditions. Extraoral examination reveals no obvious facial asymmetry, but a slight fullness of the mandible on the right side. Palpation identifies a smooth, rounded, bony hard enlargement on both the buccal and lingual aspects. Deep cervical lymph nodes are palpable on the right, but they are soft, non-tender, and mobile. While the patient's demographics and physical characteristics provide a baseline, definitive diagnostic work begins with a rigorous interrogation of the radiographic evidence. This initial oblique lateral radiograph provides a broad view of the lesion. We can observe a large multilocular radiolucency occupying the posterior mandible. By examining the posterior anterior, or PA view, we can assess the degree of medial lateral expansion. There is significant expansion on the right side, which is beginning to disrupt the typical symmetry of the facial skeleton. Consider the patient's age and race alongside these two initial perspectives, showing an expansile multilocular mass. Take a moment to formulate your primary differential diagnosis and share your reasoning in the comments below. In an advanced clinical setting, we must move beyond immediate visual impressions. A diagnosis is reached by systematically eliminating possibilities using multiple radiographic views. On the oblique lateral view, we define the boundaries. Measuring approximately 10 by 8 centimeters, it extends from the second premolar to the angle and up the ramus. The margins are smooth and well-defined. The well-corticated white border suggests a slowly enlarging benign growth. To overcome superimposition, we use a true 90-degree lower occlusal view for a cross-section. This reveals the expansion vectors. While there is buccal enlargement, the most prominent feature is the gross lingual expansion of the mandible. Examining the relationship between the mass and the dentition, this periapical view focuses on the lower right molars. The teeth are displaced superiorly. Crucially, the blunted roots show evidence of resorption, a key indicator of the lesion's behavior. These combined findings, posterior location, significant multidirectional expansion, and root resorption, provide the specific criteria we must now use to identify the pathology. Based on these criteria, the principal differential diagnosis is ameloblastoma. Epidemiologically, ameloblastoma most frequently presents in the 40 to 50-year-old age group and has a higher prevalence in African populations compared to other groups. The presentation in this case is classic. The location at the angle of the mandible, the degree of expansion, and the presence of root resorption are all highly consistent with an ameloblastoma of this size. We must also consider the strongest secondary differential, central giant cell granuloma. However, a giant cell granuloma is generally less radiolucent because it is composed of solid tissue rather than the cystic spaces common in odontogenic neoplasms. The internal architecture is also different. Giant cell lesions typically contain fine bone septa, or wispy osteoid, creating a honeycomb pattern. In contrast, this patient's radiographs show the thicker, distinct septa that produce the classic soap bubble appearance. Furthermore, while giant cell granulomas can cause expansion and tooth displacement, they rarely result in the significant root resorption seen here. Although giant cell granuloma remains a possibility, the high radiolucency and the presence of root resorption make ameloblastoma the most probable diagnosis. We should also evaluate the odontogenic keratocyst, which is a frequent consideration for large radiolucencies in this region. The odontogenic keratocyst has a characteristic growth pattern, often extending along the medullary cavity with minimal cortical expansion until it reaches a very large size. Unlike the localized outward ballooning expansion seen in our patient, an OKC typically creates a broad-based enlargement after tunneling through the bone. Because an OKC rarely causes significant root resorption or this specific type of expansion, it is an unlikely diagnosis for this case. Odontogenic myxoma is another benign tumor to consider. Myxomas generally affect a younger patient cohort, making it less likely given our patient's age of 45. We can also distinguish it by looking at the internal septa. In a myxoma, the internal septa are typically straight and arranged at right angles, often described as resembling the strings of a tennis racket. This contrasts with the rounded voids and soap bubble architecture we are observing. Finally, we can discount simple unilocular cysts, such as dentigerous or radicular cysts. This lesion is clearly multilocular. Furthermore, it is not associated with an unerupted tooth, nor is it related to a non-vital tooth, ruling out the standard criteria for those cysts. By systematically analyzing the growth patterns and internal geometries of these various lesions, ameloblastoma remains the only diagnosis that accounts for all the physical and radiological data points. We must now return to the clinical reality of the patient. This intraoral photograph confirms the significant mandibular swelling that was indicated by the radiographs. It is a fundamental principle of oral pathology that radiographic interpretation alone is never definitive. To establish a definitive diagnosis and meet the standard of care, an incisional biopsy is mandatory. The biopsy is necessary to confirm the tissue type and to rule out histological variants, such as the desmoplastic ameloblastoma, which could necessitate a different management strategy. To plan for definitive surgical treatment, advanced three-dimensional imaging is required. Cone beam computed tomography, or CBCT, is the appropriate modality for this stage of investigation. CBCT allows the surgical team to map the tumor's precise volume and determine its proximity to vital structures, including the inferior alveolar nerve. Establishing accurate surgical margins in 3 dimensions is essential before performing a mandibular resection. If you found this clinical breakdown useful for your examination preparation, please subscribe for further deep dives into dental healthcare and oral medicine. Success in clinical examinations and in professional practice requires the integration of rigorous radiographic analysis with a clear, safe pathway for definitive tissue diagnosis and patient management.